All right, welcome back, everybody. We are now about to start our operations panel. This one is called Shrink Grow the Status Quo, What's the Future of EM Operations? We have some great people here today. I'm just going to introduce our moderator, Dr. Sam Shen, who's the Vice Chair of Operations at the Stanford Emergency Department. He's a professor of emergency medicine here. Great guy. Sam, take it away.
Thanks, everyone. And I'm very excited to have this amazing panel. I wanted to first introduce all members, and then we can get started with some questions to talk about the status quo, the future of emergency medicine, emergency department operations. First, we have Dr. David Feldman. He is the head of strategic technology partnerships at Inflect Health and Vituity. He's a practicing emergency physician and a senior partner of Vituity, and chairman and medical director at Good Sam here in our local Bay Area. We also have Dr. Topher Sharp. He is the Chief Medical Information Officer at Stanford Healthcare, and he's a professor of medicine at the Department of Medicine at Stanford University. And then we have Dr. Mark Frudenik, who is the medical director and emergency services chairman, also on the board of directors at VEP Healthcare. And so thank you all for joining. I wanted to first describe a little commentary and then get into some questions, get your perspectives. When we think about emergency medicine and EDs, it's actually an access point for episodic and unscheduled care. And we know with COVID, average volumes are down 20-25% across the country. But even without COVID, I think this is a very interesting discussion to think about what EDs could look like in the future from an operational and delivery of care perspective. And specifically how technology could influence that. We typically think of the ED care model. Somebody comes in, get triaged, they get seen, diagnostics happen, and they get dispositioned to either home or hospital. And the goal is to move them through very quickly. And this is a very resource-intensive process. We've been hearing from the prior talks about the role of emergency medicine in adapting to innovations and different ways of caring for patients. We've also then heard about the push from a value perspective, shifting care away from this expensive ED care. And we know that ED visits, despite all that, still continue to rise, at least pre-pandemic. And so, intentionally, we brought this group together, and not everyone's an emergency physician, but that's great because we wanted a different perspective. So I wanted to start off by just asking each of you, when you look ahead and you think about what EDs could or will look like in the future, do you think they're going to be scaling up, scaling down because of access issues, or due to innovative alternative ways to access care based on some of the things that we've talked about earlier with telemedicine, digital health? So I'd just like to start that off with that open-ended question. Dr. Feldman, would you like to start us off?
Sure. Thanks, Sam. Thank you for having me, and Topher and Mark also. Very nice to be on the panel with you. Yeah, I think that the future and the crystal ball that I'm interested to hear my fellow panelists think is a very interesting question. I actually think I think there's a couple conflicting or sort of balancing perspectives. I think that if you look at patients and the needs of patients and patient care, it's a risk mitigation strategy or mindset. They want the best care when they need it at their fingertips. And we've also been promised in this country sort of, the best modern health care whenever we feel like we need to get it. And actually there's laws written around, the layman's definition of emergency and things like that. And so that's going to drive people to seek out care in the best way they know how. So that, and pre-COVID, that was being seen in person by a physician. Otherwise, telemedicine was not something, or remote care was not something that was really as embraced. And COVID pushed us into this whole different mindset, right? So instead of saying, okay, I'm going to go see my doctor and they're going to give me great care, now if I go see my doctor in the hospital, I go to the emergency department where I work in San Jose, I could get coronavirus, which we know very little about, and I could die. So all of a sudden volumes plummeted, people stopped coming in, and it led to other issues. And in the future, as we go forward, I think now that we've sort of cracked into remote care, digital care, people started getting used to it. I think the pendulum will start swinging back and forth. We're starting to see more people come back to the ER, although it's a slow, steady progression. And then that'll probably swing to find a new sort of new normal. But I actually think as we start to expand digital health, digital access points to health, remote care, I actually think that the emergency department and critical care and procedure rooms, ORs, and procedure rooms like cath labs will grow actually in the hospitals. So I sort of see a future, maybe if you ask me to put on sort of the futurist hat, fewer hospitals, but every hospital, brick and mortar, will actually have a first floor that may be completely emergency type care, right? 12 hours or less episodic care, people can just come on in. But the way they enter that care won't necessarily be by just driving into the hospital. They'll get their smartphone and they'll go through a digital front door, and then they'll be either directed to a different level of care, or they'll be directed to a brick and mortar care, or a unit will be dispatched out to their facility to then pick them up and bring them back, much like EMS does now. And then the other level of the hospital will be ICU level care and ORs and procedure rooms, because otherwise most of the other stuff can be done at home, or will be done at home. It's just a matter of when. And I think what COVID did for us, it was already mentioned by several speakers, is just accelerate that time frame, right? So instead of being 10, 20 years out, now it's here now or in the next 3 to 5 years, which is what's so exciting. And what we saw in the last 12 months, in my role with Inflecto and Vituity, it was actually tremendous for the amount of innovation and conversation and companies we spoke to. I mean, that went up exponentially. It didn't actually slow our business down. It actually really accelerated it.
Very interesting, because there is definitely a thought that, EDs, are you the access point for everything for everyone, or are you really just intended to be the critical care access point, and everything else should really be outside? Topher, let's move on to you. I mean, as a practicing internist, you obviously see patients in the outpatient setting, but you see patients that can also come to the hospital to be admitted through various ways. What are your thoughts in terms of, when you look ahead, how healthcare is changing, delivery of care is changing, how that would affect potentially the sizing of ED, or how emergency departments are run from the status quo?
Hey, thanks, Sam. Yeah, so speaking as a non-emergency physician, it's really a pleasure to be on the panel and to be able to join you all. I've sent Sam many a patient over the years out of my primary care clinic. And also, I think about this from the perspective of our overall health system and what this means for many health systems as we start to evolve forward. I think of the Yogi Berra quote about how predictions are very difficult to make, especially about the future. And so I think about this a little bit more of like, what are current state forces that are really enacting that would be pushing us? And, one of them is certainly one of them is a consumerism focus. So, as we digitize more and more options of medicine, there are so many ways that consumers are going to start to engage in that process more informed and in a more participatory manner. So, today, the decision about whether or not you should go to the emergency room is a part of that overall patient experience, right? The patient experience starts all the way back in these formative moments when the patient self-assesses, Googles their symptoms, and says, is this bad enough that I need to make a choice, right? That I need to go. And often I think when we think about emergency medicine, we think about the most critical, where there's just no choice. There's no question. I'm being picked up off the ground by an ambulance to be brought in. And that's only one perspective, at least as I would see it, around how emergency rooms really provide the right level of care to a community, because there's a lot that hangs out at the other end of the spectrum where the patient is actually self-assessing and deciding, what should I do here? How should I go? And around that, consumerism is going to happen in a number of ways. One of them, of course, is going to be driven by price-conscious consumers who say, hold on, my friend went to the emergency department and they were either hit with a surprise bill, or they were just, it was just an expensive endeavor in terms of money, in terms of time or other experience. And they're going to look for options around that can help them to figure out and better inform themselves about what to do next in that setting. And that's going to require probably two key points, right? One is that we're going to need to have a lot of information and a lot of options that are available. And we're seeing more of those starting to appear, certainly through the course of the pandemic, as we've seen not only telehealth, but a lot of the online, on-demand type of telehealth, urgent care type of telehealth just exponentially grow as individuals have become more sensitive to that choice, not necessarily because of their economics, but because of COVID, just as David just talked about. The other is that, we're going to look to healthcare organizations to have more of a continuum that's apparent to patients. I really would double down on this idea of a digital front door that helps patients to navigate to the point of care that makes most sense to them, helps them see all the different permutations along the way. So you can know as a patient and say, well, I have a problem, but this problem can be cared for by an online service. This problem probably can be cared for by a clinic setting. This problem really necessitates that I get myself into the emergency department. And to be able to see and navigate those different points along the way, both from a clinical and patient perspective, but also a dollars perspective. It's really important that people are informed and say like, oh, I understand this is going to be a lower cost care, but it may or may not make sense to me as we go forward. So I actually think that, one of the things that we'll see in the future, I expect, is more demand for a continuum of experience and a continuum of informed options that really help you to navigate into the right place. That doesn't mean that emergency departments won't continue to have a full spectrum of care, because that's always going to be necessary. But I think we're going to see people, consumers, as well as payers, pushing those consumers to start to use different parts of the emergency services in very specific ways.
Great, thank you. Then same question to you, Mark.
Yeah. So I love when I hear other people and it kind of fits with the way I'm thinking about things, because then maybe I feel like I'm on the right path. And so I just want to dovetail off a lot of those comments. First of all, thanks for having me here. Really appreciate that. And you'll notice in some of my comments, I think very highly of emergency physicians. I think we have great ingenuity, and we really have a great ability to see the forest for the trees, especially across the entire healthcare landscape. As you all know, we live at the intersection between the outpatient world and the inpatient world, and I think have a pretty good understanding of both, and not many physicians do. So I think in terms of sort of volume and future, as we've already seen during the pandemic, emergency physicians have gotten incredibly creative, opening their own clinics or starting infusion centers or going into telemedicine. So there's been a time where they've started to fill these gaps with their, in a sense, personal resource of time and effort and ingenuity. And I think we'll keep seeing that. But as Dr. Toffer mentioned, patients in a sense vote with their feet. They know where they're getting the value that they seek. And just a funny story, I had a primary care clinic near us who didn't understand why their patients were coming to the emergency room, and he wanted to put one of those flyers out front that would show people where it is. I said, I think that's probably an EMTALA thing. I don't think we could do that right in front. But what you need to do is improve your service, whether it's through confidence or the ability to do more stuff. For whatever reason, the patient is getting what they want from us and not from you. That's what you have to solve. It's not about advertising. And then I'm going to piggyback again. I think it's all about, in terms of both financial and outcomes, improving in our continuum of care. So we're all working in the same system. I loved what you said, that experience starts way before they reach us, when they start to have symptoms in Google. And that's exactly right. And so one of the ideas that I've really latched onto is, I think emergency physicians are great at leading that continuum of care, kind of determining based on a patient's symptoms and risk factors what level of care they probably need. So I think we should be sort of the tip of that spear of these care continuum systems, where we can be very early contact with the patient. And in a sense, Kaiser EPRP is exactly this. They like to have early contact with an ER doc, because they're good at parsing out what needs to happen now, or in an hour, or in a day, or next week, and how to get some of that done. Where, let me skip several steps. This is a patient I know from just talking to them, they just need to see a neurologist. Nobody else is going to figure this out except a neurologist. Let's stop wasting time. Let's stop wasting my time. I'm going to virtually refer them to a neurologist and just get that done. And the patient will be so happy. So I feel like I talked for a long time. Hopefully I addressed the question at least a little.
Well, it definitely kind of kicks off this the concept that a lot of us have been talking about, even the prior speaker, the idea that in a value-based mentality, we know ED care is expensive, and many of you have touched on the fact that some of the care could be delivered prior to coming to the ED, but also in a RVU-based system that we currently live in, or predominantly live in. How do we reconcile that? The misalignment of economic incentives, where in a strange way, emergency medicine is one of the few specialty that is actively trying to shift care away from us to other avenues. You typically wouldn't hear other services saying, I'm trying to reduce business to me, but we are actively trying to shift care away from the ED. And for someone in your position, Mark, where VEP runs a lot of EDs, and obviously volume is a important metric, how would you reconcile that in terms of the alignment, the financial alignments?
Yeah, I'll start right out of the gate with this analogy that I heard a long time ago, maybe 2 decades ago, kind of predicting where we were heading. And I don't think we've escaped this yet. And that's that we have one foot in the canoe of value-based and one foot in the canoe of fee-based. And how do you get upstream with one foot in 2 different canoes? And we just haven't made the real shift to value-based, which would change all of our incentives. So I think we need to keep moving in that direction and figure out, it seems to be piecemeal, how we can find a value-based system so that we're managing people in the appropriate way. I'm not trying to drive volume into the ER because I need it. I'm not trying to drive volume out of the ER because it's expensive. I'm trying to drive volume exactly where it should go. And that's what will maximize value. So to the primary care, if that's right, if the specialist, if that's right, to the inpatient ward, if that's right. And again, I think we're really good at picking that for people. Maybe not perfect, but about as good as anyone. So I think we should be at the lead point in parsing where people need to go to be cost effective.
And that point really resonates, I would say, with our Department of Emergency Medicine at Stanford, where we are very much interested in this idea of the precision emergency medicine and specifically kind of the right care, the right place at the right time for the patients. David, can you tell us kind of from your perspective as someone who's also part of a large group of EDs, how do you view kind of how the financial incentives between volume and value-based care, how does that affect, the things that you guys are prioritizing at your organization?
Yeah, no, that's a great question, Mark. Great analogy. I agree with that analogy for sure. In a lot of ways, emergency physicians are sort of one foot in the ER and one foot trying to go somewhere else all the time. It seems like that we're attracted to the 2 canoe world. I think for us, in the short term, the volume adjustments are just what we have to do to keep the place appropriately staffed and be cognizant. And that's hitting the hospitals, our hospital client partners, more than it's hitting us. And so we definitely are supportive and want to make sure that we're, prepared for the patients when they come in. I think the challenge, and actually what we're doing at Vituity, what we've challenged ourselves, our board challenged us about 3 years ago, was really to start to move outside the walls of the hospital and just to sort of reiterate on that concept of bringing care to the patient no matter where they are. And then that way you can start to leverage technology that's available to us. And then the last year, as I said, it just accelerated it. It didn't change the course, it just accelerated the time frame so that we can start to really approach that precision medicine. And I think that in larger systems like a Stanford, you can definitely have more of a presence and a view with value-based care. But in the world of Vituity and maybe Mark's world, VP is very similar in the sense that it is much more fee for service. And, we're not, there's conflicting incentives, right? Because we know globally we want to do the best care for patients. We want to be responsible to society for costs, but you're presented with an initial patient and then doing what's right for that patient in that setting doesn't necessarily lead itself to the best value-based care approach. So that's the conflict. I agree with Mark, but I think really the technology that we're seeing becoming more and more available to deliver precision care, I think is a path to lead us more toward, if not to ever leave the balance of fee-for-service and value-based care, but maybe to then sort of the technology will allow us to actually keep 2 feet in the canoe, to use Dylan Mark's analogy, but then actually allow the 2 canoes to kind of go in the same direction.
Great. And Topher, if you put on your hospital hat, as the Chief Medical Information Officer, representing the hospital's perspective, how do you view the role of EDs in the future from a value perspective? Because, on one hand, half the admissions come through the hospital, which is, great. On the other hand, you don't want all admissions, specifically readmissions, come through the hospital. We don't have a huge at-risk population that's capitated, but we're moving towards that. So, how do you reconcile all those different forces over the next, 5-10 years?
Yeah, it's a great area of challenge, as Mark and David are talking about. The transition between the current state and that assumed future state where we're going to get to a much more value-based and risk model. And I have to say assumed because I think none of us know exactly when that shift comes because there's so many factors that are influencing that. But that transition state becomes a question of not which canoe do you put your weight into, but how do you hedge across both in a way that is mutually satisfying. So I would say that our health system looks very carefully at the numbers of patients that are arriving into our emergency department and our volumes. And we know that those volumes translate directly into the volumes that are in the hospital. And we know that, a hospital with empty beds isn't a hospital for very long. So of course, those things are tremendously important, but that doesn't mean that we want to see people coming in and being in our beds, and being in our hospital. I had an interesting conversation with our CEO where he said, a number of years ago, I used to stand up in front of other CEOs, and the first thing I would do is I would tell them how many beds we have in our hospital. That was our definition of value. That was the definition of where we made our profits in order to be able to support our organization and our mission. So that was always the first number out of my mouth. He said, now I look around and I realize actually we make our mission in our ambulatory setting foremost. That's actually more of where we generate our revenues and engage our community than our hospital. Not that our hospital isn't a big piece of what we do. And he said, so now when I stand up in front of that same group, I talk about our ambulatory mission and what we're doing to fulfill that. And he said, but the question that always plagues me is like, what would be the digital equivalent? What would it be to say, we care for this many lives, have this many interactions, provide this much value in a way where we didn't even physically touch you? And that's the question I think of, like where this goes next. And that's the hedge that is both potentially profitable in a fee-for-service system or in a risk-based system. It's the way that you steer the right patient into the right service and that you cost control. And it's the way that you really provide the right value out to those who want and need it as we go forward. So I would just say, I really appreciate, Mark, your comment where, emergency medicine really, that capacity to understand and triage and find the right care, connect the right parts of the health system very, very quickly in the right way that provide that right continuum to patients. If we can figure out how to do that same thing digitally that you all do right now in the waiting room so incredibly effectively, or, at the point of triage, that seems to me like a very secret sauce that is the opportunity for emergency medicine operations of the future.
Thanks for saying that. That's exactly where we're headed, is building sort of that telemedicine interaction. We're starting with high-risk patients, let's say post-discharge patients or other multiple comorbidities or those who've been assigned into some of these high-risk pools, and having an emergency physician available to them 24/7 to sort of monitor and direct, rather than them as soon as they're feeling a little out of breath, I better go to the ER. That's where I always get fixed up. Well, let me talk to the ER doc online and see what I really do or don't need to do right now. I'll make a couple of other quick comments, although it looks like Sam's back. I was trying to cover about how to work in this double world that we're living in. And I think there's really either two options. One is find innovations and new programs that will work for both. So they work in your fee-for-service world, and there's tons of those that we could talk about, those AI-guided processes in your ED that just make it more efficient. Doesn't matter if you're fee-for-service or value-based, you're going to save on expenses. Or the other, I think, is you get yourself into risk-based contracts one way or another. Just start moving into the future, building the future. Maybe it starts small, but start carving it out and getting yourself into risk-based so that you're ahead of the game in it and you're innovating. And I think that puts you in a more competitive spot in the future.
That's a great segue into the next question I have for this group is, what are some of those technologies that you feel will influence and truly influence, how a patient's cared for from the front door to the back? When you think about all the different types of innovations that have been discussed so far, whether it's AI, whether it's hardware, software. What are the technologies that you are seeing or maybe hope to see that will truly impact the care delivery such that perhaps EDs don't need to be as big as they are now. David, you want to start?
Sure. Yeah. No. So I think that the technologies we're looking for. So at Inflect, we're pretty actively reaching out to startup companies, and we talk to probably I don't know 300-400 companies a year now. We're on that pace of just looking at all the different facets that allow us to look outside the walls of the hospital, and so we start care there, and all the different components that facilitate bringing the care to the patient, and then directing them into the hospital, and then post-hospital. So you just have that continuity of care. That's sort of a acute care continuum we're extending out, which is sort of the value prop that we our parent organization Vituity really pushes. I think the digital front door we mentioned. I think AR and VR are definitely very interesting technologies. But I really think it's fundamentally what Topher was commenting on. It's about pushing the information you need, the critically actionable information about the patient's data, as far forward into the patient encounter, patient experience as possible. So that starts through a digital platform, and then it brings in information into the emergency departments, right? It's like the first time I tried one of those electronic stethoscopes, and it was like, oh my God, I heard so much stuff. I didn't even know what to do with all that data. So it's like drinking from the fire hose, but actually taking the right data so that you can answer the question that's in front of you with that given patient, make it actionable as early as possible in the process. So looking from it with that lens, what we're doing is we're trying to dissect out all the different components so that we can meet the needs of the patient, whether it's at the home or if they have to come to the hospital, then bring them into the emergency department quickly.
Mark, I know you have a strong interest in AI, in your work. Can you tell us a little bit more about where you see the role of AI in ED operations?
Yeah, what's interesting is I feel like David just sort of gave a nice description of the way I see it without ever mentioning it, which is that, artificial intelligence or machine learning isn't really intelligent. What it is able to do is to process a lot of data very quickly and kind of offer that up to the human being to work with. And so, one of the companies that we're invested in just started with a very simple triage tool, trying to look at all the information that's coming in a triage and doing a better job of parsing them into, levels 1, 2, 3, 4, 5. And what they found is, and the program would run, and it would just alert the nurse, hey, you marked this a 3, but I think they're really a 2. And the nurse could change them to a 2 or do whatever they wanted with them. And because the ER has, 4 or 5s going to a low acuity place, and 1s and 2s getting seen right away, and 3s going to the waiting room, the results were astounding. Just by implementing this artificial intelligence tool that the nurses triage, patients who ended up in the ICU spent an hour less in the ED on average. They got to the ICU an hour faster. So sick patients did better. And the throughput time for the 4s and 5s as a group was lower because they were selected appropriately. None of them waited as a 3 in the waiting room. So just getting a little bit of more accurate information, having a machine do that processing for you up front quickly, absolutely changed the efficiency of the department, which saves money no matter what model you're in.
Great. Topher, I'd like you to perhaps also kind of comment on, because in your role, I'm sure you see a lot of companies or ideas that get pitched to you for Stanford to try. Where do you see kind of the role of AI or other technologies that can directly influence, how care is delivered?
Well, I'll be a little heretical and say that I think that a lot of the advanced technologies that get pitched to me are really, really hard to integrate because we don't have foundational technologies that they can sit upon. And that's and I don't think it's unique to Stanford. I think that we're pretty far ahead of the game in terms of the foundational technologies and the infrastructure that we've laid. But I see a lot of really cool stuff that there's no way that either it technically integrates into our system or from an experience that it integrates into our system. And so I think that we also, as much as we think about the cool future stuff, and we've got cool future stuff happening, there are pieces we can do within our own house where we've got a lot more control, and we can bring in and kind of experiment and play with, where AI fits and how it actually affects our operations or our clinical decisions and our efficiencies. And those are really important and really useful. I guess going back to our prior conversation, though, I think those will be always important, but a little bit at the margin if you're really thinking about changing your interaction model. And there you have to start to lay some of the more foundational pipes to be able to open out into other areas that you wouldn't before. Simple things like just publishing your wait times out to patients where they can find them is revolutionary and has much more, may have much more impact than whether you use AI to figure out exactly what is the very most precise wait time at that given moment. And so I think that there's a lot of fundamental pieces here. I think about things like having on-demand capabilities and the digital front door capabilities that allow patients to understand how to access those services and access those knowledge. And then those start to lay the highways where you can start to put in the cooler technologies on top, and you can start to put in the bots and the AI and the other directive technologies and predictive technologies that start to happen in those. So I just say that I think there's still a fair amount of fundamental interactive technologies. And the other one that I kind of throw out there is that, a lot of technologies maybe begrudgingly are becoming more interoperable. And that's really important because we all need to keep pushing vendors and others to be able to make these solutions that we can actually pull and parse and piece together quickly and easily. A lot of the solutions that are pitched are kind of all-in-one solutions and say, well, if you just come to my app or my website, then get your patient to my app, and from there it's going to be awesome. But we struggle to get our patients just to our own apps or to our own websites, and have to kind of take that into consideration as we go forward.
Thank you. Thanks, Topher. And thank you all. At this point, I'll turn it over to you, Dan, to field some questions from the audience.
Sorry. I think we have time for probably one question here that kind of voted up the highest, which is really around this question that came earlier around EM having a target on its back, both from startups and from value-based care. And I'd love to hear how this group kind of really thinks about how EM physicians and APPs and the whole entire staffing model that exists in the future. I'll bring in this other question here that talked about a recent EM report that said that we'll have a large surplus of EM docs by 2030. And where we are going as a community, even if the operation side is delivering the best care to the right patient.
I'll jump in and I'll start. I'll go right back to where I started. I think emergency physicians are really ingenious people, really understand the entire system, have skills that translate to lots of different levels of care, and have always had this mission to serve the patient's needs. Now, I agree, if you see yourself as an emergency physician and as a resuscitationist, and I can remember, decades ago that some people came out of residency feeling that way. That's what I do. I'm a resuscitationist, and everything else is sort of after me or not necessary. I think you're going to have a hard time carving out your new career as we get better at this. Kaiser doesn't have a ton of intubations in their ERs for a reason. Their patients are well cared for in a more longitudinal way. It's not that it never happened. So I think we have to kind of be willing to redefine ourselves. What do we want? And I think that there are patient needs out there to fill, and we'll figure out how to fill them.
Yeah, I'll echo Mark what you just said. I think that there's no group of physicians or even personalities that are quite as adaptable and willing to push themselves outside of our comfort zone so that we can adapt to the trends that are coming. Look, I think that there's, in the last week, the surveys came out, there's a lot of discussion, there's a lot of angst. If I was a resident coming out, I'd be concerned about what does my future look like. It'll have an impact, and then we'll have to look at the workflows and workforce studies and better understand it. But at the end of the day, there's a huge patient care need. The technology that we have at our fingertips now that we can take powerful AI, pair it with physicians, that has the best outcomes. When you have the physician with the AI, as Dr. Zane mentioned this morning, it's better outcomes, and there's studies about that, right? In radiology and other areas. The AI alone is not sufficient, but the physician with the AI is better than the physician alone. And so we'll figure out ways that we can actually continue to impact our patients, our communities in a positive way, add value. And then as far as, your future as an emergency medicine resident now coming out, your future is very bright. You'll make a great living. You'll be able to provide for your family. So I think that the technology is incredibly empowering, and it's just going to be what we make for it. And I think the impact we're going to make as a group of emergency physicians and the emergency physician culture and the advanced providers is going to be even more profound. And it's actually going to be a lot of fun to be a part of creating that future.
Great. Maybe I'll ask one quick last adversational question as well, maybe between Topher and our two other colleagues. So Topher, at Stanford, we are an entirely vertically integrated emergency medicine the whole way through. And our colleagues here tend to be they run systems that are outsourced from a hospital. I'd love to hear what you guys' thinking is around sort of this idea of a learning healthcare system in the future where all the knowledge comes into one place versus outsourcing parts of that hospital, and how that dynamic might play in the future in your guys' thoughts.
Hey, maybe I can jump in for a second here, Dan. Thanks. That's a nice controversial one. I'll just pick up on the last comment and say that actually everybody's got a target on their back right now. Startups and Amazon want to eat my lunch as primary care as well, right? And so I got to tell you, it's a cool time to be in healthcare. It's a really interesting time to be in healthcare, regardless. And I think, this idea of vertical integration and horizontal partnerships, that's critical, because the concept that a learning health system can only happen within your four walls if your walls are situated on a university campus, that has to go, right? That is not the future. That's not the future of a learning health system. So we've got to find ways that we actually share data, share information, and share insights, and in fact use some of the capitalist economy to help us get there, right? Make this stuff a value statement so that it's actually shared out. So from my perspective, even in the hallowed halls of an academic institution where we vertically integrate and insulate the walls, I'm convinced, from the outside sometimes, that's not actually the way of the future, and the partnerships that we all need to forge are going to be critical.
Mark, David, do you have any last thoughts around that?
Yeah, I'll jump in real quick, Mark, unless you want to go ahead. I think the idea of having this really intelligent integrated system across academic and community hospital is really pretty exciting. And then how you can expand that outside the brick and mortars of just the hospitals themselves into the community and then into the home. Because, you can create a great tool that works great at my emergency department or Sam's or Mark's. And then you've done a great tool for one place. Because every iteration, every facility, every community, it's just so different. But it's really finding that those technologies that are truly able to adapt and quickly move and then iterate at different facilities. But every time they go into a new care facility, then adapt and change and be effective in that specific facility. So I think that's where we can learn from the academic centers and start to expand and partner to really break those things down.
Great. Sam, I don't know if you have any final words before we go.
No, I just thank you. I mean, it was excellent conversation, and I love that a lot of you guys are thinking kind of very similar in terms of what the future could look like. Even though not all of us are looking at from just purely the emergency medicine lens. And again, I just appreciate all of you taking time to join us today.